I'm Dick Moberg, and welcome to our interview series. A lot of interesting people pass through our doors who are doing amazing work in brain monitoring. We bring them into our studio, put a mic on them, and get the personal stories you don't normally hear. We hope you enjoy them. Hi, I'm Dick Moberg, and my guests today are from a company called Brain4Care in Brazil. And they were the hit of the Neurocritical Care show last year. A lot of people standing around their booth, and we looked over at their booth and wish all those customers were over at our booth. So they did a really good job at the show last year. I want to congratulate you for that.
Thank you.
It was really cool. And we're here with Dr. Sergio Brasil, and he is one of the, what are you at the company? Are you the CEO or the medical? That's you.
Just Max.
Okay, good. All right. We have a bunch of other company members here too. It's we have the whole company here. Cool. Okay. And we have Claudio here.
Yes, sir.
And Claudio, what's your role?
So my role, I'm the head of the digital team, so I oversee the whole IT and product development, the software side of it, and also the analytics team. And I also help with the FDA clearance process, regulatory, and reimbursement.
Cool. And Sergio's more the medical. You're a physician.
Yeah.
In Brazil.
By formation, I am a neurosurgeon, and I work also with a neurosonology, that is a vascular evaluation of cerebral blood flow. So we met each other like 4 years ago, and we found that we were doing was much correlated, and I started to perform research with the system.
Yeah, that's really cool. And we should actually say what they're building or what they've done. And so they have an amazing bit of technology they've developed that looks at brain compliance non-invasively. And the results are absolutely astounding. I mean, I've seen a lot of people come through here with some kind of non-invasive ICP measurement. And it's kind of like, okay, well, it does kind of an approximation, you know, and it's kind of not quite ready for prime time. But their system is FDA cleared and really amazing. I mean, I just saw some demonstrations. We've had one here for a few months and tried it out, and it blows your mind, really. I mean, if you've been in this field as long as I have. So why don't you? So we have one here, and so why don't you show us what it does? And so we'll take a few minutes to do that, and then I want to talk about kind of the future and where you guys are headed and what you're doing. It's really amazing. So why don't you tell us about it? Yeah. Cool.
So this is a sensor. We typically start like the principle of operation is skull pulsation. So this was the inventors, aha moment, a paradigm shift. And so what this sensor does, you strap this around a person's head. I'm going to do this right now. And you just put it on. And then this sensor is connected to an app. And then we do it, hopefully this might show here on the camera, but here's my live waveform. If I just will be quiet for a little bit. So that's the ICP waveform we have on the app. So what this does, it captures, right, a surrogate ICP waveform, and then the app will talk to our cloud analytics, and this will come back, and then it will give you a processed waveform, the average shape of that waveform, and associated parameters from that waveform. So what this does, right, these parameters, we have been studying this where Dr. Brasil really helps us out over here. We started correlating this with the invasive numbers, right, the pressure and also compliance. That's what we're striving for. So this is ultimately the output, as simple as that.
It's amazing. And the basic information you're getting is the contractions of the skull, or the expansion contraction.
Exactly. That's how we say that, skull pulsation, right? Yeah.
I bet you come up with a lot of people and they come up to them and they just don't believe you can do that, right? Until you put it on and show it to them. And that's just amazing that you can actually do that. I remember non-invasive ICP has been a holy grail for decades. And I remember applying to the, I think it was NASA, wanting, they had money, and this is in the 80s.
Really?
This is in the 80s. Okay. And we were trying to do something fairly similar. And they had some money, and we didn't get it, but I know they wanted to give it out to people. But I don't think anyone did it. And you guys finally did. So really amazing.
Thank you.
So let's talk about the applications. I mean, there's clearly applications in what we know now to be the indications for intracranial pressure, right? So those are some. But we were talking earlier. One of the things that really amazed me is you are now able to go into populations and look at ICP that no one would ever look at before because you wouldn't want to drill a hole in their head. Do you want to talk about just some of what you told us earlier about what you're seeing in these populations?
First, I think I'm going to defer to Dr. Sergio, which is a true clinician here.
Okay. Yeah,
I can give an engineer's perspective to it.
No, in fact, in many situations, it's not ethical to make a burr hole in the skull and put a catheter over there to have information about intracranial pressure. So we just deny the existence of intracranial hypertension because we can't monitor this. So, but as medical literature has evolution for years and years, we found that many systemic diseases can impair intracranial compliance. So, is fundamental to monitor this, but sometimes we can't do this because performing a burr hole, we have the risk of bleeding or any kind of complication, and sometimes we have situations that we have coagulation problems, so we can't do this. And in other situations, the patients were talking to us, and they have complications of chronic disease that also have problems with intracranial compliance. So to make this kind of diagnostic is pretty hard. It's pretty difficult. And also this adds a new information, and I think some amazing thing about it is not just because this is a device or a hardware to get this information, but also to analyze this, because as a physician I always look at the waveforms when I have a patient with an intracranial catheter and subjectively interpret this. So where are the peaks? Maybe I think this waveform is impaired. I think this waveform is standard. So this was in the hands of the physicians. But now we have an automated analysis of the waveform that is pretty new, and we have parameters derived from a physiological process. So I think it's much more reliable than just looking at some kind of point of intracranial pressure, of value intracranial pressure, and take some decision about the patient. So it's not just a hardware, but also a software that is analyzed for us and give us parameters and information in real time at the bedside, anywhere in the world.
Yeah. And you were seeing changes in different age groups, is that right? I mean, that's just amazing.
This we know this is like expected situation, because as we age, we have also differences in the CSF, or the cerebral spinal fluid transit between our skull and our cervical. This transit is impaired according to aging, and our compliance is a little lower as aging, and so the company is still finishing the analysis of a big population of healthy people to take the real thresholds according to aging. But we know that this is a phenomenon unnoticed before, but expected. And now we have the opportunity to put this in the paper and publish it.
It's something that nobody's been able to look at.
Yeah.
It's amazing. Yeah. And one of the things that the parallels to kind of the life I've led is, I started out in making EEG monitors for people who hated EEG, or basically EEG monitors for people who knew they needed it, but they didn't know anything about EEG. And so my first 20 years were basically making EEG monitors for anesthesia, right? And so we went in there and we made a simple EEG machine where an anesthesiologist could use it and look at like carotid endarterectomies, is the brain okay while they're clamping the carotid, and then we added evoked potentials, and so you could look at spinal, monitor the spine while they're doing disc surgery and that kind of thing. And another thing happened in neonatology. So, in neonates that had a hypoxic ischemic encephalopathy, EEG became a way to determine whether they should be cooled or not. Well, the neonatologists knew they needed EEG, so some people invented a really simple EEG machine. It wasn't a big, huge machine. It was one they could do. And I see you kind of doing this same path, is that you're giving people a way to look into the brain, with a very important measurement in a way that's extremely simple. Yeah. So that pediatrics could use it, and you were talking about using it in anesthesia and all these things, and so some really good parallels there in what you're doing.
And to your point, about the application. So you mentioned one, right? Our current bets, right, is anesthesia, and they'll do neuroprotection during anesthesia. Also, like we've had currently in Brazil, it's being used, right? We have a pretty good number of hospitals and clinics using this. In a hospital setting, like we've heard a lot of clinicians, for example, for cardiac surgery, post-cardiac surgery, I'm in the ICU, so I'm really worried about, protecting the patient, but also there was nothing over there that was giving a good look at what's happening to the patient's brain, right? Perfusion, right? So that's one application that we're calling in turn like hemodynamics management, anesthesia. There's a third one we're looking at, it's really acute brain injury, TPI being a big chapter of that. So that's typically like the inpatient scenario to it. But to your point, the easiness of it, just putting it on your head and having like variation over time of those parameters, hydrocephalus, the whole patient journey to help diagnose it. After I put a shunt valve, is it working or not? After the adjustment, if it was good or not, did I drain too much or not? Lumbar puncture is another one we're betting on. And finally, idiopathic intracranial hypertension as well. So of the many applications, and sometimes you feel this is almost like a blessing and a curse at the same time.
I know.
So many shiny objects right in front of potential. So let's focus on certain areas. And partnering, right, with people is something that is very important as yourself, right? It's very important for us to partner because we know that, alone, this is just the beginning, but with people around us, it's a much, greater potential.
Yeah, and thinking and talking about information. So when we have any patient sedated and under mechanical ventilation, we don't have their neurofeedback. So we must rely. It's like we are driving on instruments. So with the evolution of the technology from last 20-40 years, we now can cover blood flow or blood flow velocities with transcranial Doppler. We can cover the electrical activity of the brain with the EEG. We can cover all the techniques have their limitations, but we can cover also the oxygenation of the brain with the NIRS. And now we have also an information on compliance. Yeah. So we have almost the perfect model, completely non-invasive, to have all the information about all the things that are happening in the brain of our patient that is sedated, and the only the situation that is escaping this is like microdialysis. Microdialysis is still it's costly and only exclusively invasive. So, but we can cover a lot of phenomena occurring in the brain of a patient that is unaware. That's amazing.
And I think it's going to be interesting. The more you get this out there, and the more they correlate compliance with other physiology, that's going to be really important, because then you start to say, okay, I see this other physiology, and I know compliance can tell me, that's changing or whatever. Just like that case you showed us, with the child, that was amazing.
This is a snowball. One thing will repair the other, and
exactly.
The cycle.
Very, very, very exciting. So you're doing trials now at Hopkins and Cleveland Clinic. Is that two very kind of lower ranked universities.
Yes, yes. We try to go like low end, right? Over there. Yeah.
Like 2 at the top in the country.
Yeah.
So very good. That's very cool.
Yeah. So currently, our footprint in the market right now. So we're really starting to getting into the U.S. market, really understanding what's happening. So we're really partnering with these institutions that we have had the opportunity to have their interest, right, and also have that partnership for the trials with these Ivy League institutions. But we're also looking for pilots, right?
Yep.
We're pretty open. It's an FDA cleared device, right? And so we've also had going into events, NCS, SCCM, people coming by in our booth, and then we are right now starting to see, hey, people are getting interested. So the idea is like, let's have a pilot, have a trial with that. Yeah.
As the applications are pretty wide, so let's do this. We have a large avenue of research to run still, but we have now with our publications shown that the waveforms are correlated if you have the invasive information and this non-invasive. So we have this predicate. So now we must understand and study how the therapies and how the actions I take to treat my patient impact this information and vice versa, and map all the applications we can use this information.
Yeah, it's amazing.
Next step.
I think one of the things I'd like to do, maybe we don't do it, maybe it's I'll add it to the end of this video, is with you, and I'd love to show close-ups of these reports and everything. So
let's do that.
I think what we'll do is I'll just take close-ups after this, and we'll just put them in at the end of the video, and maybe you can narrate that, all right? So maybe we can do that.
Perfect. So actually, we have a report here of how my ICP behaved while we were talking over here, right?
Let's see what happens. How are you doing?
Well, technically, I seem to be sane.
Good,
right?
all right.
That's one thing, right?
I'm glad I don't have it.
Yeah.
No, it does illustrate, the kinds of things you can do with ICP just sitting around and talking. And I know I've seen you stand up and hyperventilate and those changes, but what else could we see? Does it change in dementia? There's all these things you can, and migraines and all this stuff that we probably don't know about. That you just wear these with all these conditions, and I think it's going to open up a whole new world for us.
And that's where you see, I'd say internally, we're probably too close to it, right? And sometimes, we don't get as excited as we should be because probably too close to it. Because sometimes, looking at our analytics team and going through all these analyses, we have the privilege, to have like these hypotheses coming in, and then we help them answer these hypotheses. Mm-hmm. But really, when it boils down to, it's really unlocking a very important information in a very easy way, close to zero risk. Put it on, measure it over time, look at these parameters over time, and then that's just the beginning. Yeah.
As I work with those kind of Doppler waveforms every day, I learn that this crucial information. The waveforms don't lie. It's up to us to understand what they are saying. This is the challenge.
Right. Yeah. And in TCD, that's been around for many years, and I think we kind of know what the waveforms are telling us. Mm-hmm. The problem is everybody would love to have a TCD system where you just put it on your head, and it finds the middle cerebral artery for you, and it just does it, right? Just like what your system do. I'd love to have a TCD system. Yeah. There are some robotic systems, but I don't think they work that well. But that's the beauty of what you've done. I think is you're just making it accessible.
That's right.
Cool.
Thank you.
Good. Well, anyway, I want to thank you all for visiting us, and this has been a fun conversation, and I wish you a lot of luck in this company. I know you're excited about it. I'm excited about your technology, and I wish you a lot of luck.
Thanks for having us.
Sure.
Yes.
Thank you very much.
Cool. Thank you very much for the opportunity.
All right, we snuck down to our conference room to get a more detailed look at the Brains4Care technology. So this is going to be what's under the hood in that product. And this is Claudio. So Claudio, tell us about the waveform here.
Perfect. So what the Brain4Care sensor, right, will capture is the surrogate ICP waveform. So over here we're looking at an example of an ICP waveform, the typical 3 peaks, right, of the ICP waveform. What we're looking for is the first and second peak, and one parameter that we estimate in our device is what we call the P2P1 ratio. So this means what's the relative size between the second peak and first peak. And in general terms, if the second peak is smaller than the first peak, that's good, better. But when you start having a second peak bigger than the first peak, that's where the literature is saying that it's more correlated with increased intracranial pressure and also loss of compliance. That's the first parameter. But what we also wanted to add to our analytics engines is what we call normalized time to peak. So what is this over here? If we consider the beginning of the pulse's length over here as 0% of the time of the pulse's length, up to 100% of that, the normalized time to peak is how far out into the pulse's length is the maximum amplitude. And the hypothesis behind this is if the maximum amplitude is sooner, meaning that this normalized time to peak is a smaller number, it means it's more of a P1, meaning that P1 is bigger than P2. Now, if this higher amplitude is more towards the right, it means that it's around here in the region of P2, meaning that P2 is bigger than P1. So this is a calculated number. And we put these two over here just to make sure that you have these two parameters. And in the future, near future, we believe that putting these two things together, they will give you a nice scale, that these combined, you have a scale of 1, 0, 1, 2, and 3, that we're calling this intracranial compliance scale.
Great. Now you're going to show us how it works?
Yes, that's
All right, let's go over here. All right, cool, good.
So,
All right.
So let's show how the device works. So here's the device, it's a sensor, it talks to a phone. So I have projected my phone over here. So we have an app, it's a iOS or Android version of the app. So I'm seeing here, we can see that the app is open. So what I'm gonna do, I'm gonna turn on the sensor, and then the app over here is gonna recognize that there's a sensor close to it. So I click over here, and now there's a pairing option over here. So I have both app and sensor blinking with the same light and frequency to make sure that the correct sensor is connected with the mobile device. So I can have this on a phone, on a tablet, and many places have a tablet on a workstation in an ICU setting. So we have an initial screen over here that you can fill in patient information. There's an API that will do the integration that will pre-fill with this. Or you can skip this step and start the monitoring session. So over here, I'm going to put my phone down here. I'm going to put the sensor here on the table. So you see that the sensor is capturing the vibration of the table. And if I tap here on the table, you can see it's a very sensitive pin. And now let's get my surrogate ICP waveform. And there you have it. It's that simple. So what the app is doing right now in our cloud system, we're collecting a 30-second sample of the waveform. This is a technical verification that we do to make sure that the waveform is good enough to be processed in our analytics engine. So once you put on the sensor, you can see this is the processed shape of that waveform. You have the average shape of the waveform with the confidence interval, and it refreshes every 5 seconds. So if you're comfortable with it and that waveform is good, you can start the monitoring session. And this is the screen we have for the monitoring session. So it is a live waveform. That's one of the device's output. It's the surrogate ICP waveform live for you, right? On the left side here, you have information about external and internal battery that I have here on the sensor. It can go for 24 hours, right, on, and then you take the battery, charge it. This is still working because it has the internal battery, and then you could put this back in the sensor. And then you can monitor the waveform. While you are monitoring, you can also have a look at the trend. So this looks at the overall trend, and you can see over here is when I took off the battery and put it back in. So there is a characteristic that you need to follow, is that the patient needs to stand quiet. It is a mechanical sensor. So that's one part of the monitoring session, to make sure that the subject is standing still. So this is the waveform. What you can do over here is this little button. You can add notations to the monitoring session. And so over here, a clinician can write down anything he feels is important during that monitoring session. He can change the patient position during that monitoring session, and he can do that notation over here. And I'm going to save it. And what I'm doing over here, what the cloud system will do is every minute at a time, this live waveform is collected, it's sent up to the cloud, and then that is processed. And once you have that processing, over here on the right side, it's going to show up a little button having you have 1 minute of monitoring that has already been processed by our cloud system. So I'm going to click over here, and this is the second output of the system. So the first output is the live waveform, and the second output are the associated parameters for that waveform. So you have the patient information that you would fill in that first part over here. This you would have like information about the sensor position and the patient position, any clinical context for the patient, and this is the first processed minute. So what we have over here is the estimated P2P1 ratio with confidence intervals. For every additional minute, it adds to this graph over here. And here in the bottom, we're going to see the exact shape of that waveform. So this is the average shape of the surrogate ICP waveform. We have the estimated P2P1 ratio. And down here are all the parameters for that minute, right? So you have the estimated P2P1 ratio with confidence interval, the useful pulses. The analytics engines will clean out any artifacts. So if you have too many artifacts, you're going to have a reduced percentage of pulses that were useful. Over here, 86%. I'm talking a lot over here, that's why. This is the derived heart rate, and that's the normalized time to peak. So those two parameters we're talking to you, we're showing these are the two most important ones: estimated P2P1 ratio and normalized time to peak. And if you go down on the last page of this report, you have the overall monitoring session, the total monitoring session. You have a minute-by-minute heart rate. The first minute has been processed only, so that's why I have only one. Heart rate, derived heart rate, a normalized time to peak with confidence intervals, percentage of useful minutes, and also the pulse amplitude. This refresh button is telling me that now I have a second minute that has been processed. I will refresh it, and I have 2 minutes that have been processed. This second minute over here, it has that notation I wrote down on it. So when I do a notation, I will have that second minute for which I did a notation right at this moment of the minute. I have the raw signal, the average waveform, the most important parameters, the ratio, the time to peak, and here is what I wrote down as a notation for that minute. And the second minute has also been added to this minute-by-minute view of the device output. And that's how it goes on for every minute I do it. And that will also add to the last part of the total monitoring session. I have the 2 minutes right now, and the same for all the other graphs. And I refresh it again, and I have the third minute, and so on. So in very simple terms, that's what the device does. So you just put it on your head, connect it to the app, you have your surrogate ICP waveform, and the two outputs, the live waveform and this report.
Well, that's great. Thanks.